All right. Well, I'll go ahead and get started. So, good evening, everybody. Thank you for joining us for our first of 3 sarcoidosis survival checklist, self-advocacy and sarcoidosis patterns. I'm Mindy Buchanan, Director of Patient Programs with the Foundation for Sarcoidosis Research. And first, I would like to quickly thank our sponsor, Boehringer Ingelheim, for supporting our education webinars this year. So thank you to BI. And sorry, now I need to get out of my show. Always happens. And next, I'd like to introduce you to FSR patient advocate and navigator, Frank Rivera, who is going to introduce this series in memory of our friend and patient advocate, Rodney Reese. And to share a bit about Frank, Frank is and has always been a fighter. His strength and care for others is what personifies him and makes him Frank. He is deeply committed to the sarcoidosis community and serves as the president of Stronger Than Sarcoidosis as well. Frank also has published a book about his experience with sarcoidosis called Walking in Silent Pain, and he published that in the winter of 2020. Frank, I would like to turn it over to you, and I will share a photo of Rodney as you're chatting, if that's okay.
Sure. Thank you, Mindy. Well, let me just start this off saying I am going to read this out because I did write this out. It is a little bit hard for me. All right, so let me just start by saying this is probably the hardest thing I've ever had to do speaking-wise. So, bear with me on this one. My name is, as said, Frank Rivera. I want to thank FSR and Dr. Leslie Sakatu for honoring my friend and brother, Rodney Reese. With this sarcoidosis survival checklist series, starting off with session 1, self-advocacy and sarcoidosis patterns. I was invited to kick this off because, as many people know, Rodney and I were good friends and sarcoidosis advocates for greater than 10 years. We were the two of the original FSR ambassadors, and I considered him my brother. He was a very special person and a passionate man in everything he did, whether it was about his city of Baton Rouge, his history, his family, of course, and of course, sarcoidosis. When I met him, we talked about life, family, but everything came back to how to help others with sarcoidosis. He always wanted to know how I was doing, and always asking me, what is the next thing we can do for the sarcoidosis community? Well, one day he told me, and this is his exact words, "Hey, Frank, you have to meet this amazing doctor, Dr. Leslie Sakatu. She is starting this great study that will not only help the community for COVID, but it would also raise awareness for sarcoidosis. But most importantly, it will help patients in their everyday life." And I can't and won't try to do justice the way he always says it with his excitement as well. But he had me sold with his first words. Those that know him know exactly what I mean when I say that. We worked closely with a great international group of patients, doctors, researchers to understand patient experiences of diagnosis, management, and survival before and during the COVID-19 pandemic, which led to deeper understanding of these issues, informed 2 publications meant to improve living life with sarcoidosis, with hopefully more on the way. But you see, for Rodney and I, for Rodney and I hope I can probably speak for many of us that were involved in getting this published. That wasn't the end goal. It was all of us that got to spend time with each other. That especially rang true for Rodney. We loved every meeting, the researching, the joking, the bonding, and all of us that I feel the bond will never be broken. We knew we were helping the sarcoidosis community. These FSR sessions, presented by Dr. Sakatu, address the concerns and knowledge gaps that Rodney and I have repeatedly voiced and heard voiced among the sarcoidosis patient community for years in navigating care and health when living with sarcoidosis. These sessions underscore proactive tools and perceptions for better living and survival that persistently emerge in our research on sarcoidosis. Thank you again.
Thank you so very much, Frank. And We would like to now take a minute of silence in honor of Rodney. So I'll start that now. Thank you, everybody. And thank you again, Frank, for that wonderful introduction. It is now my pleasure to introduce this, to get the series started. And with that, I want to go ahead and go over some quick housekeeping for everybody. So as a reminder, this session is being recorded and it will be available to everyone along with the PDF version of the slides and any links that are presented or discussed during this session. We'll address questions at the end of the presentation, so please add your questions via the Q&A bubble at the bottom or sometimes at the top of your screen if you have it set up that way. We will try to answer as many questions as possible, but we may not get to all the questions asked today. And reminding everybody this is session 1 of 3, so there's more opportunities for more questions down the road. As a reminder, please try to be as broad as possible when asking your questions. We know how unique sarcoidosis is, but it's important to note that our experts are not able to provide direct medical advice. So with me today is Dr. Leslie Sakatku. Dr. Sakatku is a researcher, educator, and clinician in scleroderma, sarcoidosis, myositis, and pulmonary hypertension and interstitial lung diseases. She's a director and founder of the New Orleans Scleroderma and Sarcoidosis Patient Care and Research Center. And beyond clinical trials and registries, Dr. Sakatku's research work is deeply rooted in patient priorities, expertise, and perceptions. Exercise is a disease-modifying treatment in these conditions, as well as an embodiment like mindfulness and physical activity, targeted anatomical strategies such as dance and yoga to improve health outcomes in cardiopulmonary conditions. Welcome, Dr. Sakatku.
Thank you so much. And thank you, Mindy and Frank. Thank you so much for that very fitting tribute to our dear colleague. There we go. And welcome, everybody. It's wonderful to be here. It's an honor to be here again with FSR, and very grateful to have this opportunity to share some of the work that we have been doing. So these are, I'm just going to flip through funding, support, and just once again, a picture of our dear beloved colleague, Rodney Reese, an inspiration, great being. So here we are, the Sarcoidosis Checklist series. So this is a series, and Mindy has been awesome in helping organize this and plan it. And it is going to be so far three sessions in the series, one dedicated to patterns of self-advocacy and sarcoidosis. The second, medications. Again, patterns of medications, what to be aware of, things that are essential to know in some of the most common medications and how to tolerate them better. And then lastly, is going to be the sarcoidosis symptoms and health-related quality of life. And that's going to be a convergence of a lot that we're talking about now. And we're going to be able to break down further into more detailed experience, and also help patients understand better what, in terms of a scope of symptoms, they need to be looking for in terms of red flags, things that they might be concerned about, and mimics and ways to increase one's quality of life that may have to do with interaction with the healthcare system or the way that we make choices and habituate more healthful living, in addition to directly dealing with sarcoidosis symptoms as well. So a lot of what we're going to be talking about in this series is derived from our work, which is a series of research meetings that really started back in 2017, I think it was. And a lot of this research had to do with contemplation about screening, what patients are frustrated about in terms of understanding, what clinicians might be frustrated about in terms of understanding the disease, and where the health system and the operations of a health system lie within all of this, and what increases one's sense of quality of life, which we now know is tied to survival, and what are the things that tend to diminish, and then what can we do to enhance quality of life and prevent its diminishment. So, so here we are today, the sarcoidosis survival checklist, focusing on sarcoidosis disease patterns and self-advocacy. What we're really here to do is get familiar and cultivate some concepts that will emerge into patterns that will help us better see patterns of disease, patterns of symptoms, understanding why we may be sent for certain tests at certain times and not others. And very importantly, recognizing that not everything is sarcoidosis. Sarcoidosis is so unique, and it's sometimes very overwhelming for most healthcare providers that they become blinded by the fact that somebody has sarcoidosis, and therefore everything going on with that person is by default in their minds having to do with sarcoidosis, which is not the case, and that could be a huge pitfall in optimal care and health in these patients. And then we'll look at other patterns to cultivate in terms of communication, how we prep for our visits, how we organize the results of our tests, and our rights and responsibilities as patients, and self-management that goes a long way in chronic diseases. So that's a tall order for today. And I've got my phone here to keep me on target. Okay. So one thing I'd like to say, after all of that long list of goals for today, and remember, these are patterns, these are concepts that can't be learned in one sitting, but they're concepts to be practiced, to be integrated. And as we do so, they get stronger in our life. And so this is part of habituation, a cultivation. And part of that is to be friendly with ourselves and know that we all mess up, we forget things. And one of the most important things that you can not do is beat oneself up, because that just doesn't help the situation, but it goes to learning. So there are cues for learning. So everything here can't be learned in a day, can't be integrated in a day, but it takes time. So be nice to oneself. So let's just take one moment or 2-3 moments and get a sense of the core of habituation, which is simply allow oneself to fall into one's best comfortable self as much as possible. And the way we can do that is through mindfulness techniques or any other type of breath-body connection technique. Take a moment, take your hands, let them rest on your belly, or let your arms rest by your sides, and just allow your eyes to softly close. or be cast in a hazy gaze in front of you. And just notice the sensation of your belly or your abdomen and how that pressure, the intensity of the pressure, waxes and wanes against your hands or your forearms or even your upper arms. And just let your attention ride on that wave of the intensifying and de-intensifying pressure between your abdomen and your hands or your upper arms that's caused by the breath as it gently finds its way into the body. And you may hold there or not. And as it exhales from the body, and try to allow your attention to just ride on that sensation wave. Now, of course, the mind is going to wander because that is what minds do. And if your mind wanders, which it will, just smile at yourself and invite your mind to come back once again to rest its attention upon that changing sensation. And with the next breath cycle, allow the eyes to gently open and return back to our virtual space. Beautiful. So here we go, part one. And these are the motifs that are recurring when we're considering treatment or not treatment, or how aggressive to be treating sarcoidosis. And so getting more familiar with these patterns that are going to be presented will help us better understand decision making and help us be more astute in the questions that we want to ask our specialists. Sarcoidosis, as we all understand it to be, is a multi-organ system disease, and it's often a multi-organ system disease, although we tend to think of it as predominantly pulmonary. We tend to think that beyond pulmonary, it happens more frequently in the eyes and in the skin, but actually we think that the other organ involvements have just many times been missed, underreported, and maybe as a medical community, we've just not been hypervigilant in such, in investigating these. We know from epidemiologic studies and registries that sarcoidosis can be either a self-limited disease, it can peter out on its own, we can wait for it to resolve and for symptoms to go away, and that happens in a large majority of patients. But in a significant proportion of patients, it can be progressive. And that is important to pay attention to, the signs of progression. So one thing that we don't want to wait for is, there we go. I'm having a little bit of, let's see. Having a little bit of difficulty with
Wow, Dr. Taki, sometimes, is it very strange? Sometimes stopping your share and starting to share again will fix it.
Oh, I love that idea. Okay, stop the share. There we go. Stop the share. Let's start the share again. Let me try it one more time.
Okay.
Yeah. Here we go. Did it actually stop? Okay, there we go. Okay. Dun 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 dun. For some reason, it's let's see if this will work. It's giving me a partial view from current slide. Ta-da. Bump. Yay! Okay, hooray. So we don't want to wait for what we don't want to wait to see if it will resolve, if the sarcoidosis will resolve, is in the eyes, because they're very delicate and the damage is lasting, and we already know it often requires treatment. The nervous system, or the heart, when we know it's active in the nervous system, when we know it's active in the heart, we don't want to give it a chance to show us whether it's going to resolve or not. We're too nervous for that. So what is a granuloma? So a granuloma is the hallmark of sarcoidosis. We consider it to be an immune system reaction to an antigen, and that antigen is any substance that the body reacts to. And this could be maybe and this happens in many different diseases. This could be if you get a splinter, if you have some sort of foreign body. This is the body's way of protecting itself. And for example, in tuberculosis, we rely on granulomas to wall off the infection. And so the immune system notices the antigen, and that little purple dot is an antigen. And this is an immune cell. So this immune cell is recognizing this particle that shouldn't be there, or this particle that signals danger, and it signals the rest of the immune system and riles the rest of the immune system up, recruits them and says, hey, pay attention, assemble yourselves. And they do. So that it recruits these immune cells and it surrounds the antigen, and the granuloma ends up protecting the body by walling off whatever this is, and this splinter, foreign body, infection, and preventing invasion and preventing spreading through the body of this infection. And so we see this in many different health conditions, whether they're acute and fleeting or whether it can be lasting. So in sarcoidosis, what we see happening is that the antigen drives an overreaction of immune stimulation. And in sarcoidosis, we think that this is either remnants of an infectious protein that's left behind, like just like strands of a few chains of proteins or some chemical, and either it's controlled, it ends up being controlled and cleared by the body, as we see in some patients with sarcoidosis, or it continues to stimulate the immune system in an ongoing immune reaction. Oh, guys, I'm gonna try it again. I see. So, bump, 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 bump. Thank you, everybody, for being so patient. let's see. Okie dokie. Bing, bing, bing. So everybody they were again revisiting, because remember, everything is repetition. Okay. And so what happens in sarcoidosis and some other health conditions is that, well, we're not really looking at a single granuloma. We're looking at an aggregation of granulomas forming kind of larger masses, or forming chains in certain organs. Again, here we have our immune system and this little purple antigen. And then what happens? It shouts out, hey, we need help. And help comes on the way. And then we get a aggregation of granulomas. And that speaks to the burden of granulomas that we might have, and exactly where they are and how they trail. But one thing that I want to point out is that granuloma aggregation, it can be related to future behavior. Oh, my screen went off. Oh my goodness. I hope
We still see you.
you see it. Oh, fantastic. Okay, I've got a blank screen. I've got a black screen. So I'm doing this from memory. So on the middle of the, there
now
we
it's
go.
fine.
Now it's black.
Yeah.
Hmm.
You want to, if you want to email it to me, I can put it up for you.
Oh, I think that's a great idea.
You'll just have to tell me when to push the button next.
Yeah, I think that's a great idea. Let me also. Okay. Says, oh, snap.
We need like a commercial break, everybody.
Oh, yeah. I'm so sorry.
That's okay. We all of us have struggled with fun time with Zoom and fun time with PowerPoint this year and last year, right? It's become a daily activity for most of us, I think. Everybody understands.
Sure has. I don't know. This has been unusual, though. This has been particularly unusual. I'm having a little bit of trouble. For some reason, it seems to be taking a lot of internet space. Let me close this. Yeah, for some reason it wanted to. Okay. All right. What I'm going to do is, as my Gmail is and my 2-lane email, I closed it because it always dings. I'm going to just try try one more time because I closed those and maybe we'll be okay. But I am going to wait for I'm going to just give the Gmail a chance and see if we can barrel forward while I'm waiting for it to reload.
Good.
From current slide. Okay, so here we go. So far, so good. So in terms of granuloma aggregation and future behavior, I wanted to point out something that can help folks visually. So here we go. In the beginning, there is the antigen and the body's immune system. It gets riled, recognizes there's an issue, it forms a granuloma. Now this granuloma can either resolve and dissolve and dissipate, and then you get resolution, or it can move on to fibrosis. And what I want to show everybody is, I know folks haven't taken pathology, but what we see in these right-hand panels, these are granulomas. And if you look at this top picture, this top box, what you're going to see is there's a lot of darker dots here, and so what that signifies is the center of a cell, the nucleus of a cell, and that tells us there's lots of cells that are making up this granuloma. All around here, lots of dots. And so there's lots of cells, and those are immune cells. And with treatment, these immune cells can bust up. Or if you're lucky, they can resolve on their own. But in, again, a significant proportion of patients, this inflammation goes on to create scarring. Now look at the difference between the top frame and the bottom frame here. And what you're seeing here is you're seeing sheets of shiny pink. And there's very few dark cells, meaning there's very few dark dots, meaning there's very few cells. And so what this is scarring, are the stuff and the compounds that create sheets of scarring. And you can see that also here in the center of what was a granuloma, now transforming to scarring, is that there's much less cells in here, those tiny dots, as are in here. And so this is what we're trying to prevent in order to prevent damage. So have a look at this diagram. Take a minute, notice that we may start off in sarcoidosis, especially the fibrotic kind, the kind that moves forward, that's progressive, with a lot of inflammation. And as the inflammation persists, hangs around, doesn't resolve, or doesn't get treated, it's exchanged for fibrosis and scarring, which is actually damage that can't be treated with pharmaceutical medications. And so as inflammation moves forward, it leaves behind in its wake scarring. And so with that is the permanence of symptoms and the permanence of disability. That means that we have much more harder time getting back to baseline, getting back to somebody's freedom of how they felt in moving in their life, in terms of their breathing or in terms of their moving, etc. So what we try to do is we try to target treatment during this window of opportunity, which is inflammation. And in diseases like sarcoidosis, that when they're progressive, you can have a combination of inflammation and damage. So whatever scarring there is, it may not change, but there's opportunity to treat whatever damage there is, whatever inflammation there is, an opportunity to quell it. So this is just a block of text to remind us that unremitting inflammation, we call that maybe disease activity or progression. It can result in irreversibly damaged tissue. And inflammation leaves behind and continues. It will continue until it tires out damage. So inflammation is treatable, resolvable, and with immune modulating medications, but damage and scarring is not treatable with immune modulating medications. So there we go. So aggressivity of treatment decisions. This is another important paradigm. Aggressivity of treatment decisions is driven by the location of involvement, the speed with which the progression appears or is demonstrated, and the probability of whether it will remit or resolve. And usually if there's rapidity of symptoms and increasing or worsening of symptoms, that's a marker that is a prognosticator to tell us that this could be some serious disease, that if we don't quell it now, it may cause damage later. And then there's other markers that tell us that too. For example, if somebody has kidney stones, if somebody has very high calcium, if somebody has facial sarcoidosis involving their facial skin. So those are some of the concepts that we worry about. And we're also concerned in certain populations like African Americans and very possibly Hispanics that there may be a genetic predisposition to having more severe disease. So, and we also take into account patients' perceptions of their symptoms. The patient, what you tell us, is very important in the decision-making process and how you're experiencing your disease, and also your preferences of treatments. Something to understand about inflammation. Inflammation happens in many scenarios. So for example, we see inflammation happening with infection. So just because there's signs of inflammation, for example, on the blood work or signs of inflammation on a PET scan, that doesn't necessarily mean just because somebody has sarcoidosis that it's sarcoidosis causing that. It could be a concomitant infection, like a pneumonia, a urinary tract infection, a sinus infection. Another common cause of inflammation or looking like someone has a lot of inflammation is malignancy and cancer, in addition to the other autoimmune or autoinflammatory diseases like sarcoidosis. But inflammation is the body's mechanism to protect itself, and when we're talking about autoimmune and autoinflammatory type diseases, the immune system is overreading a problem. It is overreacting to a problem. So, and again, what we're trying to do is we're trying to distinguish between active disease and old damage, because we don't want to use immunosuppressants when it's not necessary. And if all somebody has is old damage, again, immune suppressive treatment is not going to make those symptoms go away. But if there's some inflammation there and mixed up with old damage, then we might be able to gain some ground for that patient. So it's worth treating. And so we want to pay attention to those issues. And just because there's something on imaging, some sarcoidosis patterns in the lungs or in the bones or even around the heart, it doesn't necessarily mean that it's active. A lot of the times, what we're picking up is old damage. And so we have to figure out a way of how do we decipher whether this is active disease, sarcoid disease activity, or is it old damage? And so this requires a lot of thinking and a lot of discussion between the patient and the clinician. And the biggest things that help us is to understand is whether there's any new changes or worsening on imaging or in some of our other tests that we do. And if we're unsure, especially if it's like a high stakes organ, and if we're sure that there's nothing else going on, but we're unsure if the sarcoidosis is progressive or not, sometimes we will say, listen, we're worried it's in an organ that's very sensitive, or these symptoms have been progressing kind of rapidly, but nothing's changing on the scans. Why don't we have a trial of medication? Because it might be in your best interest, weighing the risks versus the benefits. And then we would observe what happens after immune suppression. So those are kind of important treatment approaches and treatment patterns. So how do we go about detecting active sarcoidosis? Well, focusing on imaging, we have to understand that nothing is foolproof. We tend to think like things that emerge from the medical profession, whether they're labs, whether it's imaging, we kind of feel so in awe of these wonderful techniques and machinery and technology that we tend to think that it's the end all and be all and it must be the word, but they're fraught with mistakes. They're fraught with artifact. They're fraught with inability to pick up small patterns that if we actually obtained some tissue, we'd be able to see it, but we don't sometimes want to obtain tissue because it's maybe harmful to do so, like in a turkey part of the brain or the lung that you just can't get to easily. So, but these tests, imaging, they're wonderful, but they can overread and they can underread. And like I said, the clinically meaningful sarcoidosis may be too small to detect it on imaging. And imaging is also vulnerable to technical issues of positioning, body shape, in certain uptake tests that we use for imaging, the body's chemistry, even like, did you have too much glucose, for example, or too much sugar the day before, or a high fat, or too much fat the day before. So those things can, but what I want to impart are the patterns of these modalities and what these modalities are used for. So, because otherwise it just feels like you're drowning, could potentially be drowning in all these different tests, not really understanding why they're being gotten. But we're going to try to break it down in a very simple way. And we're going to look at the most common images, X-rays, CT scans, PET scans, which are often done with CT scans at the same time, and MRI, and try to understand a little bit why some are used and some are not used. Sometimes they're used and sometimes they're not used. Okay. So X-ray, very simple. It's a picture. That's all it is. Bing, it's a picture. It takes a picture from front to back. And what it tells us is it provides us shadow and grades of shadow. No shadow, lots of shadow. So air comes up as being completely black. And then the gradations of gray occur based on the density of the tissue. So here we can see bone. Bone is very white because it's very dense. Here you can see just the shadow of skin. So that's kind of a gray area, right? And then all around this foot, for example, you see air. And so here in these lungs here, you see air. You see the vertebra, which is very dense, bright white light. And then in this chest X-ray, you also see some grayish shadows, some hazy shadows, suggesting there's some other type of tissue or fluid. So here we are. These are chest X-rays in sarcoidosis, and you can see this between the ribs. All we should really see is black, except for the heart, which is a different shade, and the diaphragms, but we should really be seeing black because we need to see air in the lungs. And where there's not black, and here these are lymph nodes, we can see that it's being, there's something not going quite right. If we look to the right of the screen, we can see this foot. What do we expect a bone to be? We expect a bone to be white, is what we expect a bone to be, because it's dense. And so, but look at what we have here. Here, a sarcoidosis patient, their foot, we have not deeply white bone, which means that the bone is thinning here. And that happens in inflammatory diseases, the bone thins, and it happens with prednisone, the bone's thin. And what do we see here? We see an incomplete bone. This is a toe bone. What we should see is this all being filled in with white. And it's not. We have this hole right here, which tells us that there's some kind of a cyst or a hole in the bone that shouldn't be there. And this is sarcoid bone disease. And we can see this happening here, these moth-eaten areas of what should be just dense white bone. But again, it's just a picture. And this is what it's telling us. It doesn't tell us anything more in terms of, at this moment in time, as to whether it's active disease or old disease. If we had two pictures next to each other of, for example, if we had this foot and we had it from a few months ago, and the same image showed a much smaller black hole here, then we'd get the idea, well, this is getting bigger and this is progressing. But that's kind of all that the X-ray can do. It's a picture and it's done with radiation waves. Well, CT scanning came along, and what this is, it's like an X-ray. It's done with radiation and it's done with radio waves, but it's a 3D beaming of these rays and providing us with 3D imaging so that we can look more finely at texture, and we can even look more closely to see more well-defined like blood vessels here. And we see texture where we couldn't see that before with the plain old X-ray. So what we're seeing here on the left is we're seeing a cut through the lungs. And what we see is we see the lungs here. And again, yeah, we want them to be black. We're seeing some nodules though. Can you see these dense nodules? That's scarring. And you see this is a vertebra. It's appropriately white, right? Same sort of concepts as we saw in the X-ray. But we're able to see here that there's some scarring and there's some things here that should not be here. And that's a patient with sarcoidosis. Turning now to the right-hand panel, what we're seeing here is the liver. And what we're seeing here on the liver, this liver should be this sort of homogenized grayish area here, right? Well, all those little sort of gray dots. But what we're seeing is we're seeing some white dots in here. And that's telling us that there's something going on that shouldn't be there. Maybe it's scarring, maybe it's inflammation. And so that's the difference between X-rays and CT scans. CT scans, they can help us a lot. Again, they can tell us what shouldn't be there and what should be there, what's not there that should be there. But a lot of the time, it can be difficult to tell what's inflammation and what's old damage. There's some things that can tell us inflammation, but oftentimes we have to rely on more finer imaging techniques. So here we have some images of MRIs. Now, what is an MRI? An MRI, again, is the 3D image, and it provides deeper cuts, though, and different, the way that we can view different organs is much, much finer. We're not using X-rays. What we're using is vibration of water in the body and water in the organ to tell us what's, to create a picture, of still and shadows and enhancement patterns. But but what we can see here that we don't see very well on CT scan is we can begin to see nerves. We can begin to see when nerves are encroached upon. We can see in a much more granular way the appropriateness of certain tissue. So, for example, let's look at the left-hand panel. So the left-hand panel, this is a slice of the heart. This is the chamber of the heart, the ventricle, the big chamber in the heart. And what we're able to see here is we're able to see that here's the heart muscle. You see, all of this is the heart muscle. The heart muscle has picked up the contrast from the MRI, and so it brightens. And so what that's telling us is that there's either inflammation or there's scarring happening here. And what we don't usually or easily see on the heart, though, is inflammation, is swelling, is edema, which is something that we rely on in MRIs to tell us that there's inflammation, is that swelling that happens. But we don't usually get a good look at that with the heart. But in this case, we do. So what we have here is we have this bright enhancement. Still, we don't know what this bright enhancement is, but guess what? Right next to it, we see that there's some swelling. So in this case, the MRI tells us this could be inflammation and not just scarring. So we need something better for the heart, which I'm going to show you in a minute. So, but in the brain and the spinal cord, we like the MRI. The MRI, we can see the nerves well. We can see confluence of swelling, and so if we look in this center panel, you see this bright white spot. This should not be here. There's something wrong going on. Well, this could be old damage, or it could be active disease. But what tells us that it's active disease is that this is got more swelling around it. It's a bit darker. We don't use PET scan, and we're going to talk about PET scan in a minute, in MRI. We rely in brain, in spinal cord, we rely on MRI because it can pick up the edema that's in the tissue. And the edema is what happens with inflammation. And that can help us differentiate, once again, between damage versus active sarcoid disease that needs to be treated with immune suppression. And so here I'm not going to bore you, but here we have the same with the spinal cord. You get the idea. So what's next then? So what's next is the PET scan. The PET scan is something that's quite wonderful. Again, it's 3D imaging. It's 2D imaging, as we can see up here. This is pictures of somebody's PET scan in terms of their scouting pictures, and it's also 3D. So I'm gonna go through this in a moment. But what a PET scan is it you're given radio-labeled contrast that's sugar, that's glucose, that's radio-labeled. And where it's being picked up tells us there's inflammation. Remember that inflammation can be infection, it could be malignancy, it could be sarcoid. And oftentimes it could be just artifact because something didn't go right in prepping for the test, or something in relationship to the body's composition. So just keep that in mind. So here we are, the heart. Remember when I showed you that picture before, I said, wow, wow, wow. Here, we can't really tell sometimes in the heart if the MRI enhancement is meaning just scarring or inflammation. But you see here, what we see here in this picture is that the heart muscle picks up the PET radio labeling very well. It drinks it up when there's inflammation. So if we look at this left panel here, we can see the heart. It's just a dark gray. It's not a black. So that's normal. And here you don't see anything lighting up. Here's the heart on this PET CT. So there's nothing lighting up. But when we look at this image here, look at this heart muscle. This is the chamber. This is the muscle all lit up. And right in here is the chamber of where the blood is in the heart. But you can see when you look at this above panel of the scout image, that whole heart is black, which means it's picking up that PET scanning, telling us that there's inflammation there. And so inflammation, it can be diffuse, it can be patchy, a bit here and a bit there. It can be both diffuse and patchy. Now, this is on the right-hand panel here, what we're seeing is pictures of the lung. Take your eyes down to the very bottom, the third panel. And what you're going to see here is a CT scan. Now, remember what I said, a CT scan is great, it helps us, but it doesn't differentiate necessarily between old damage that can't be treated with immunosuppressants and active disease, especially in one moment in time. If you had a series of them 3 months apart and you could see that the new one has got more involvement, then you're thinking this is worsening. But you don't actually have anything to delineate inflammation. Well, here we have the PET scan of the lungs. So what we're seeing here is this scout imaging with clear black bits in the middle, right? Just black, black, black. So, and then here we have in the other PET resulting is we have it lit up. We have the lungs lighting up like a light bulb. And so what is and some of the lymph nodes too. So that's telling us that there is active inflammation. So again, okay, let's look at a few scenarios here just so we can get a little bit of the hang a little bit more in different scenarios, looking at the eye, the brain again, the heart, the lung, just to kind of, again, to review these patterns, because it's these patterns that are going to help us understand why somebody wants to treat us. And also to help us advocate for ourselves when we feel we should be treated, or maybe when we need to get a second opinion. So here we go. Here we go. Can I ask?
Yeah. Oh. You're on mute.
PowerPoint opening again. Do you think you could control as well as me, or did you already try that?
Of the PowerPoint, I don't have it.
Oh, I mean, to take control of the mouse, I mean.
Oh, I can't unless I have the PowerPoint.
Okay. Do you want me to try it again to send it? Or do you want me to just continue because we were doing so well?
It was going so well, guys, right? It was going along and it was great.
Let's try it again. Okay. Okay, so here we have the eye. So when we're looking at the eye, what do we do to detect active disease? And we're talking about in the globe of the eye right now, inflammation in the eye called uveitis, which is not uncommon in sarcoidosis. So patients sometimes get frustrated with me because I'm sending them back and forth to the ophthalmologist because I need the skills of the ophthalmologist. I don't have those skills to look inside the eye to see with their special lights and their special skills, extraordinary skills. See in this, see all these white bits? These are inflammatory cells floating behind the eye, in the globe of the eye. And that can only be seen, we want those to disappear. We don't want there to be 2, 3, or 100. And the only way to know, really, except for patients that might have pain, is if the ophthalmologist can tell me what they're seeing. Is it better? Is it worse? Has it completely resolved? Or to find these other patterns that look like granulomas, or look like inflammatory leakage, or here we find scarring. So this patient here, this is scarring from the point of view of an ophthalmologist looking in the eye, to say, well, I don't see any inflammatory cells. What I see is scarring. I'm afraid the vision isn't going to get much better than this without corrective lenses, etc. So, but that does not mean that for other parts of the eye, like when there's sarcoid in the eyelids or the muscles of the eye or involving the nerves, that we don't try to look with the MRI to get, again, a better look at the muscle and look to see if there's inflammation in the muscle, and maybe have a PET scan. So the eye. So in the heart, so here we go, the heart. So it's so organ dependent what we're choosing. So in the eye, we saw we needed one way to look for active disease. So here in the heart, we really rely on patient symptoms. Are you having more trouble breathing? Are you having more fluttering? Is it or palpitations? Did you faint? Did you fall out? Are you having heart failure symptoms? Like, is it difficult to lie flat without getting short of breath? Are you waking up in the middle of the night, gasping for air? So these are the things that we rely on patients, and we'll talk more about symptoms later. We rely on EKG changes. So an abnormal EKG makes us worried for active sarcoid. Again, an abnormal EKG could just be the remnants of damage gone by. But if it's abnormal and we've not seen an abnormal EKG in a patient before, we want to investigate that further. We may get an echocardiogram, which is an ultrasound of the heart, so that we can look at the heart's function and make sure that the heart is behaving properly. We may get, we like to get a cardiac MRI always, even though it doesn't give us full information about the heart sometimes, because it will tell us if there's enhancement. And maybe we don't know if that enhancement is scarring or if that enhancement is active inflammation. We might then just rely on patient symptoms to tell us if their symptoms are getting worse. We just must treat the patient. Maybe it takes forever to get a CT, a PET scan to show that the heart is drinking up inflammation because the insurance company is being very difficult. So we go ahead and treat based on an MRI maybe, and based on the patient's clinical report of what they're experiencing. So that's the heart. In the lungs, what do? Well, we often tend to rely on the patient's report. Is the difficulty getting worse and becoming more breathless? And what do the pulmonary function tests say? The forced vital capacity, is that getting lower and lower? We might get a repeat chest X-ray, because if we compare the new one to the older one and it looks like the new one is worse, then we're worried about, number one, is this worsening sarcoidosis? Could it be an infection? Could it be something else? So then we might proceed to, on the bottom panel here, a CT scan and get a better view. If we still feel like we can't say whether this is active damage, active sarcoid versus old damage, we then may go ahead and get a PET CT. And here you go. You see this PET scan lighting up, showing us that indeed these changes that we saw on the CT scan is active damage. So in the brain, same thing, relying on patient symptoms. Is anything worsening? Headache worsening, new onset seizures, weakening. We rely on patients to speak up. Where are we when we look at the MRI? How has it changed from last time? Is there more involvement? Is there surrounding swelling or edema? And again, PET scan is not so helpful in brain because the brain is very active. And so that causes a lot of artifact with the glucose being picked up because the brain uses a lot of sugar and glucose to keep working. So, but one point of advocacy, if anybody wants to put any device inside of you, whether it's a pacemaker or a defibrillator, please make sure it is MRI compatible. All patients with sarcoidosis should have implanted. It should be an alert to the physicians to whatever's going to be implanted in that body as much as possible, be MRI compatible, because we're going to need to possibly perform an MRI on a patient with sarcoidosis at some point. So please be mindful of that. And if your doctor doesn't bring it up, speak up. So the bone, here we are again. We saw this one earlier. This is a picture. We don't know if it's active or not. If we got a PET CT, we might be able to, if we got a PET CT, we might be able to see that this hole is drinking up glucose. And here in this case, we see bone involvement. We see this CT scan. We see that there is some deepening here, some whitening where it perhaps should be less so. It's more pronounced. There's enhancement here in this MRI. Sorry, it's MRI. I said CT before. And so if we get a PET CT, what we're going to see in the PET scan, we're going to see this bone is actually drinking up the radio-labeled dye. And that's telling us this is active bone disease, and we may be wise to treat it. Take a breath. So another important paradigm of disease activity and is often fraught with a lot of misunderstanding by clinicians is the role of vitamin D and calcium in sarcoidosis. And here is a place where patients really need to be super advocates for themselves to understand these concepts. Because vitamin D and calcium are very, very closely related to granuloma burden. And so the main players in this vitamin D calcinosis spectrum are the granuloma itself, because it makes vitamin D, and the culprit that gives misinformation, which is the 25-hydroxy. Say it with me, 25-hydroxy. Like, I don't know if you remember those Oreo lookalikes, Hydrox. Think about, if you remember those, you can think about that, 25-hydroxy. So, but the one that's really high when the 25-hydroxy can be low is the 125 dihydroxy vitamin D. And that 125 dihydroxy vitamin D is what's happening, is what's happening in high levels and elevates calcium. It's the one that eggs on calcium to be higher. So that is the one that we want to make sure that is not being used as a screening test, 25-hydroxy. So just a quick overview of what happens. Vitamin D, the precursor of vitamin D, often is made in the skin when the sunlight hits it. And then we get a pre-vitamin D scenario. It goes to the liver, it's transformed to our unhelpful lab test, the 25-hydroxy vitamin D. And this is in a normal person, goes to the kidneys where it's then created to be 125-dihydroxy. And then that goes to receptors that starts to absorb more calcium and mineralizes bone with calcium. But what happens in sarcoidosis is, dun, 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 we have a granuloma. Now, this granuloma doesn't want to know about 25-hydroxy. It is just elated to spit out the 125-dihydroxy, or known as calcitriol, and that's what it does. And so it is going to be spitting out lots of this. And therefore, the calcium metabolism is going to get elevated. But because the body works on a feedback system, this one may look low because the body is still trying to protect itself from too much calcium. But little does it know that it's making this one look low in vain, because this granuloma is going to keep spitting out the 125-dihydroxy, which is going to impact the elevation of the calcium in the blood and the urine. So in sarcoidosis, peeing out a lot of calcium happens in about 30 to 50 people, 50% of people, and 10 to 25% experience elevated levels in their blood. Urea is pee, and emia is blood. So why is it less in the blood than it is in the urine? Because the kidneys are working hard. Because when it senses that the calcium in the blood is high, those kidneys work overtime to urinate out as much calcium as possible. And so what ends up happening is that it keeps the blood calcium low until it's just too overworked. And then that's when the calcium levels in the blood start to show higher in blood tests. And that is the reason that people with sarcoidosis can get, one of the reasons people can get renal stones, kidney stones, is because of the kidneys working so hard to get rid of all the calcium that's being produced by the granulomas. So, and if you do have high calcium or high calcitriol, 125-dihydroxy vitamin D, you want to be in the sun cautiously, because what you're going to be doing is ending up making more vitamin D that way. So 25-hydroxy vitamin D is not the screening test. Everyone else in the world is going to use that as a screening test, but not people with sarcoid, not alone. The one that you need to be getting when you're getting screened is 125-dihydroxy. You can also get the other one to see how low it is, but that's not the decision-making lab test for a person with sarcoidosis. So calcitriol and calcium levels. One of the things that I want to point out is that if you only have sarcoidosis in the eye, a very small area, there's not a lot of footage or square footage of granuloma. So people with very little disease, but severe disease yet, like if a little bit in your heart in the wrong place, in your eye, in your brain, maybe you don't have a lot of granulomas, but they're just in the wrong place, causing a lot of problems and can cause a lot of damage. That's not enough granulomas, perhaps, to produce a high calcium. So don't be fooled just because you don't have a high calcium. that you may not have a severe presentation of sarcoidosis, and that if you have a serious involvement like eye, nervous system, brain, spinal cord, or heart, that just because you don't have high calcium or high vitamin 125 dihydroxy vitamin D doesn't mean that you can wait it out and see if it's going to get better. Those are high stakes areas. So now, coming to patterns of diagnosis that we need to consider. Sarcoidosis has many mimics. Sarcoidosis mimics many other diseases. And overall, sarcoidosis is a diagnosis of probability because we never really have a very specific way of diagnosing sarcoidosis. It's not like if you're a diabetic and you get an A1C that's very, very high, we know you're diabetic. It's not like if we sample tissue in a person with a high-grade malignancy and we can say, this malignancy is a small cell carcinoma of the lung that's responsive to X, Y, and Z. Granulomas happen in so many different scenarios, not just sarcoidosis. So it's always the diagnosis of probability. And that's why it's so important to be an advocate for yourself, to talk about symptoms, to highlight other areas of your body that could be helpful in establishing the diagnosis. And so here what I'm doing is I've put forth an algorithm. So you have a potential patient here in purple that could have potentially sarcoidosis. So again, it's a diagnosis of probability. If you're able to get a biopsy, because you're not always able to get a biopsy, you know, if you have, even though we like to have a biopsy that shows us granulomas that have a consistent pattern with sarcoidosis, it's not always possible. Sometimes it's in a very bad location that will cause more damage if you go to try to attempt to get a biopsy. So we have to let it go. But if we do get a biopsy, we want to make sure that biopsy isn't tuberculosis, isn't any fungal element, fungal entity, isn't malignancy, or any other cause. And when we're looking at the granuloma, does this look consistent with a possible sarcoidosis? Because that's all you're going to know. Is it looking consistent with a possible sarcoidosis? If yes, then along with a pattern on imaging of where it came from and some other clinical features, we might say we feel pretty good that we can go ahead and consider this sarcoidosis. It's a high probability that this is sarcoidosis. If we try, but we're unable to get granulomatous tissue, or the tissue doesn't completely look at all like granuloma, but it's still possible, we're still going to look at other diagnoses. We have to continue always considering other diagnoses in sarcoidosis, especially with new findings. And we'll talk a little bit more about that. So the other issue is if we're not able to get any tissue, are there features suggestive of sarcoidosis on imaging, on the skin, in the eye? Is it behaving like sarcoidosis? If we have a biopsy, okay, that helps a lot, very highly probable. But if it's negative, we have to look at these other features. We don't like to depend on ACE levels because they're not specific, and many of us don't rely on them. If they're high, it's helpful. If it's responsive to, and if they go down with treatment, that's helpful. We may look at some other features. There's some clinical features like lupus pernio, which is sarcoidosis on your face that tends to look very specific. Those things, other features. And so if we put all of the things going on with the patient together, is this weighing towards sarcoidosis? Okay. If not, if we feel we can wait to treat it and still hunt for other diagnoses, we will. If we feel that the organ is too high risk and maybe we want a trial of treatment to see if it gets better, then that happens too. It's not a perfect world. Sarcoidosis is certainly not a perfect, discrete world. So it's essential to keep an open mind for clinicians and patients. Keep a questioning mind for new changes, changes in symptoms, changes in the way things look clinically. And remember, sarcoidosis is never fully proven, like we can with cancers, most cancers, and diabetes, for example. It's a diagnosis of high probability or not. One pattern of thinking that I wanted to talk about was baseline screening with new or suspected sarcoidosis, high probability of sarcoidosis. So we have here many different sites that we can look at, not just one. People present with having trouble breathing, and sometimes all they think about and all the clinician thinks about is the lungs, but there's so many clues still. So we wanted to screen for other areas of involvement. We want to ask questions, ask the patient questions about other organs. We want to do a full examinations, different parts of the body, and we want to do appropriate testing so we can prevent bad things from happening, being on the lookout, knowing the baseline probability that somebody could, for example, develop heart involvement. So the understanding and establishing the extent of sarcoidosis in a probable diagnosis of sarcoidosis is important because it tells us what other sites are being treated. And so so for example, I may not look at the skin. If I don't look at the skin, if I don't ask the patient about if they're having any skin lumps or bumps, then I am missing another opportunity to help me gauge whether there's active sarcoid or not, because the patient's treated, does very well. The skin lesion that I never saw goes away, even though it was a clue that I could use in the future. I've lost it. So, and then the lungs start to appear to get worse, but the skin is not getting worse. So that clue is not there for me to help feed into and weigh whether this is active, whether the new symptoms the patient's experiencing is active sarcoid or not. And so these are very important. The other issue is that if like I said, sarcoidosis is a diagnosis of probability. If you're just hanging all your hats on one organ to tell you everything and don't look anywhere else, you're always going to wonder, is that diagnosis complete? Again, so if I bother to look at the skin of a patient, see a lesion, take a pinch of that lesion, and it has granulomas, I feel much more confident about my diagnosis also. So that's another reason that understanding and more or less staging the extent of sarcoidosis at time of diagnosis is important. So again, symptoms always merit further investigation. So if your doctor is only focusing on the fact that you had difficulty breathing, but you're having palpitations, those palpitations need to be worked up as possible heart involvement. So that's a point of self-advocacy. Or you're having this itchy lump. These things need to be investigated, and if the doctor's not asking, you must bring these up. And this will be discussed more thoroughly in the further sessions. So most of us send our patients for a dilated eye exam, even if they present with just lung disease and they don't have symptoms, because sometimes inflammation in the eye is painless. But that doesn't mean that it's not destroying structures of the eye that can impair vision later on. And also, ophthalmologic examination is necessary if you're going to start somebody on hydroxychloroquine or Plaquenil. And having said that, if you send somebody for an ophthalmologic examination for sarcoidosis, or because you're going to treat them with hydroxychloroquine, guess what? The medical insurance should cover it, should cover the eye exam. Because I know a lot of insurances don't necessarily cover routine eye exams. But in this case, it most should. I think they have to, actually. So other baseline exams, we want to know how a person's heart rhythm is at baseline of sarcoidosis, because just in case they need another EKG down the line, just in case they start to have symptoms, we want to know, has this EKG the same as when they start, the one that we got months later, the same as when I met them at baseline, or is it worse? The same with pulmonary function. Even from my thinking and many other sarcoidosis doctors' thinking, even if someone just has skin sarcoidosis or just in their eyes, we want to get a baseline breathing test, because they could, even though they're not experiencing symptoms, they could be having some impairment related to pulmonary sarcoidosis. And we want to know if it was there at baseline before we start treatment and it disappears, because we want to know how extensive disease is in any one person. And the same with chest X-ray. We want to get a chest X-ray. If the chest X-ray is abnormal, we might want to get a CT scan. We often get CT scans in our patients because it is more sensitive. So many of us will get a chest X-ray just at baseline, but in addition, at baseline, we will get a CT scan in a patient with sarcoidosis. So we want the clinicians to do a thorough skin exam, a joint exam, especially in the lower extremity, because that's where sarcoid likes to hang out, a thorough neurologic exam. So what we're trying to do is disclose other areas of sarcoidosis that may not be in the forefront of the patient's mind. And we may get these tests. A lot of these tests, we don't know what to do with them, quite frankly. Some may be helpful, some maybe not. It's very patient dependent. ACE levels, if any of these are abnormal and they change with treatment, sometimes they can help us. The ACE level, the interleukin-2 receptor, SED rate, and CRP, those are markers of inflammation that are sometimes elevated in people with sarcoidosis. Whether or not the lymphocyte panel is lower, some of the cells on the lymphocyte panel. Also looking at if the vitamin D levels, 125, are very high, or if there's a lot of urine in the calcium. It's very individual, and really they're not meant for diagnosis. These are really meant for, if they're abnormal, maybe they can help with monitoring how a patient responds to treatment if they normalize during treatment. But nothing takes the place of a thorough history. We're going to talk about that more, and the importance of knowing your symptoms and being able to talk about your symptoms in the third installation, and a clinician's thorough asking of questions. And for you to know what those questions are ahead of time, so you might be able to think about and supply those answers to the clinician. So again, different organs experience sarcoidosis damage and sarcoidosis inflammation differently, and that's going to affect our treatment of them. And again, very importantly, not everything is related to sarcoidosis. We get dazzled by the fact that we have sarcoidosis or a patient has sarcoidosis. And so then everything that goes wrong with that patient can sometimes be blamed on sarcoidosis. And common conditions need to be considered, because common conditions can be deadly, and common conditions can destroy a person's quality of life and are treatable. So just as an example, dyspnea, which means breathlessness, shortness of breath. Yes, you could have sarcoidosis interstitial lung disease, but you could also have something else treatable going on, like pulmonary hypertension, or you could have a cardiac arrhythmia, or you could be anemic, or be physically deconditioned, or have a muscle involvement, sarcoidosis muscle involvement, causing you to have shortness of breath. So many things. So shortness of breath alone or breathing tests alone don't clinch the issue of what's going wrong. Again, cough, there's so many reasons. Many people with sarcoidosis, when they take a deep breath in, then they have pulmonary sarcoidosis, they cough, 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 cough. It's a very disabling thing. But cough can happen with many other things too. We can't just assume it's sarcoidosis. We can have a drip, we can have a postnasal drip, we can have bronchitis, we can have heart failure and cough. And the most common thing is reflux. And many of us cough with reflux. So it's really important that we're asking the right questions as clinicians to get and doing the right investigations and keeping our minds open. Keeping up with age-appropriate screening. Sarcoidosis isn't the worst thing that can happen to people. You have to keep up with age-appropriate malignancy screening. It's essential. That's pap smears, prostate evaluations, colonoscopy. If you're a smoker, lung screening exams, if you were a smoker. Common conditions should always be considered: pneumonia, infection, coronary artery disease like heart attack and stroke, malignancy. And in our patients, we screen yearly for sleep apnea, because sleep apnea, if it's present, it causes a lot of problems in patients with sarcoidosis. Whether or not it's related to sarcoidosis, it's prevalent, it's higher in sarcoidosis, as we know, but it causes a lot of problems. And it's easy to screen for with a simple questionnaire to assess how tired you are and how much you fall asleep, as well as a stop bang questionnaire, which if it's high, if it's high risk, ends up being high risk, we might send you for sleep study. And you can do these online yourself and then let your physician know, look, I scored high risk on the stop bang. I think I need maybe to consider getting a sleep study, because if we intervene with sleep apnea, we can make a lot of things better in sarcoidosis: fatigue, muscles, breathing, alertness, cognition, heart, protect the heart in sarcoidosis. So this is an important area. So motifs for cultivating self-advocacy, part 2. We made it. So this is the second, we're just almost out of time, but connecting with the guru. What do you want to do, Mindy? Do you want to? This is short. This is a shorter bit, but I'm completely of understanding if folks have to go, or if you want to stop it here and meld it with something else.
Well, I think we're at 90 minutes, so I think we should go ahead and stop if we can and bring this into the next session in November, if that works.
We can. Yes, absolutely. So I'm gonna. But one thing I want to remind everybody is that this is all habituation. You had a lot of material today. We're just recognizing patterns. We're just learning to recognize patterns. And merci beaucoup for letting me chew on your ear. And yes, I think I figured out what happened. When I was moving the bar, I think what was happening is I was moving the bar and it was hitting the new share button, maybe. So I stopped doing that.
Fun with technology tonight, for sure.
Yeah, that's weird. It's something that I do in my meetings and stuff, but I guess maybe it takes too much memory for that. But in any case, but it's great. It was a wonderful experience. And thank you, Mindy. Thank you, Frank. And thanks to everyone, including Mr. Reese, who provided so much effort to elucidating these important concepts for patients' understanding of living with sarcoidosis.
He definitely did. He definitely did. Thank you so much, Dr. Sakaku. I'm sorry, guys, we didn't have time to answer questions tonight, but I will go. I see that they are there. And so what I will do is I will go ahead and pass them on to Dr. Sakaku, and maybe we can get those answered for next time. Thank you all so much for coming and spending your time with us. And this session is recorded, so you will get the video link to it. Probably not tonight, but tomorrow. It takes a while to upload it. But yeah, so we'll definitely send that out. And thank you to everybody who came. Thank you to Frank for that beautiful introduction. Thank you, Dr. Sakaku, and thank you to Rodney for his contribution to all of this as well.
Thank
Good night,
you.
everybody.